Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. All right, listener questions with Ashley. Happy March. Spring is approaching, but you would never know it because it's 12 degrees outside. Freezing. It was in the 60s this week, but it's like 12 degrees now. All right, some quick stuff. I am going to be, or I guess we are, going to be brand ambassadors with Frontline Optics. So you will get a discount code, a podcast discount code. So stay tuned for that. I don't have it yet. The sponsorship thing I've alluded to is still in the works. It does look like it's happening. I was a little like, hey, I think I got ghosted because I met with them about the sponsorship thing and I thought it went well, but then I didn't hear anything. And the lady who coordinates it for the company, she had something very bad happen in her family. So she apologized for that and said, it's not you, it's me. So I was like, no, don't even worry about this. Just get through all of that and then no rush at all. I get questions about the store on Instagram. And if you want to go to the Instagram store, you go to my Instagram and there is a link, store, right at the top. So that's how you access that. But Ashley, is it in stock? Because people are always asking about patches and stuff.
Yeah, so I, partially my fault, I just looked at everything today. We do still have some limited merch left, but it looks like the inventory is at zero. So we actually do have a little bit more. I'm going to re-up the store today, so you should see that. We have just a few stickers, and we do have quite a few patches left. There are, I know the original patch that a lot of people like is very limited at this point. So if there are things on the store that you guys see but look like they're limited and you would like us to get back in stock, let us know. I've been telling Mike for months that he needs to get some more merch because it does fly out the door and there are certain things that people like more than others. So let us know if there's a specific patch or sticker that you guys really like a lot and we'll try to get it back in stock.
All right. And with that, let's get to the questions. There's a bunch of questions. I hope we can get to all of them. There were a lot of questions. I had to pare some down. But this is what we got. So take it away, Ashley.
All right. Number one, should there be physical fitness or agility testing for new hires in EMS, and how about yearly?
Yes, 100%. We have an epidemic of fats in EMS. I'm not saying that you need to be a calendar model or that you need to be the pinnacle of physical fitness. But I think back to, I had a call with a paramedic student a few years ago. It was July. It was like 100 degrees outside. We had to hop a fence and carry the bag and monitor probably a half mile down a trail to get to the patient. And yeah, it sucked. This paramedic student was gassed, out of breath, quivering, sweating. So am I saying that we need paramedics and EMTs who can run a mile in 5 minutes? Absolutely not. I think that's great if they can, but do you need to be like that? No. But we have, I would say, the majority of EMS providers, over 50% conservatively, could not run a half mile without stopping, even at a slow pace, could not do 20 push-ups in a row, could not do 20 sit-ups in a row. That is abysmal. So, yes, I think there should be some agility testing. Basic agility testing. Just, can you do the job? Kent County EMS in Delaware, one of the few things they do well, in my opinion, is, I don't know if they still have it, but they had a physical agility test that was pick up 30 pounds and carry it 25 yards and things like that, and bend down, touch your toes. It was things like that. I worked for an agency once that was going to have a company come in and do a fitness assessment of the department. It wasn't going to be a requirement thing. They just wanted to get a fitness status of the department. You would have thought they were docking us $5 an hour the way people reacted to it.
Oh, like they just were freaking out about having it ahead of time.
Out about it ahead of time. They're like, oh no, they're going to make this part of our And the department was just like, hey, we just long term want to see what we can do to reduce workplace injuries.
That's pretty, like, I don't know. That seems odd that people would get that upset about that. Like, to me, that seems like you already know that you're not cut out to be able to do the job physically and you're not in shape if you're that upset about it.
Yeah.
That's wild.
So there has been, rightfully so, in the last 5 years that I've been doing the podcast, a huge drive for awareness of first responder mental health, which is great. Breaking the stigma, resources for people to get help. That's critically important. Also critically important is some degree of physical fitness, physical health. And you heard Dr. Sullivan come on and talk about it for 3 hours on the podcast. But it's critically important. There is a new podcast out that talks about first responder physical fitness, and it's called the Tailboard Talks. Angie, she is a firefighter paramedic from Illinois, I believe, and she and her partner have this podcast where they talk about first responder physical fitness and physical health. I think it's good. You should check it out. So yeah, there should be some physical fitness agility testing. Again, just basic. Can you safely physically do the job? Because if you can't carry a set of bags up a flight of steps, you are abysmally out of shape. And I would opine you can't do the job safely or effectively.
Well, I always go back to you've mentioned this on a previous podcast, probably a while ago, but I always go back to the call that you had kind of very, very early on as a new medic, and you guys having to climb up a bunch of flights of stairs to a second or third floor, and I think FTO was so out of breath that the patient offered his oxygen to the field trainer.
That is a true story.
That is unacceptable. That's not okay.
I probably would have driven home after my shift and just parked the car in the garage and run it.
That's pretty bad.
Yes.
So,
Yeah, no, I think there should be some physical agility testing. Yeah. I have on here a note. This is kind of interesting. I don't know how to tie this in, but I guess I was thinking about different things to talk about as far as physical agility testing. The New Jersey State Police, did you know that they can get as fat as they want?
I think you told me this one other time. They just can't continue getting promoted.
Yeah, they can't get promoted if they don't pass their yearly physical fitness test.
But they don't have to stay within a certain standard.
Yes, because the New Jersey State Police, if I had to do my life over again, I'd probably try to be a New Jersey State Trooper. They're great. By the way, since we have a public forum, let me bitch for a second. Why is it that the Delaware State Police, I love them. I love their aviation unit. I'm friends with them. Why, though, is there a fender bender on the highway during rush hour?
Not even on the highway, on the shoulder.
6 troopers shut the highway down, and it's just shut down forever. I don't get that. But in New Jersey, we'll be landing on the turnpike or on 55, and the New Jersey troopers pretty much have push brooms pushing the bodies out of the way to get the roadway back open.
Yeah, I don't know. It is significantly different, and it drives me crazy here that it takes so long to close. Everything's shut down for so long. But
well, anyway, I think the New Jersey State Police look sharp.
Yeah.
I mean, I think their uniforms are awesome. They're always squared away. They're always fit. And I saw a really fat trooper, and I was like, what the hell is that about? And then I found out that you don't need to pass the yearly agility test. All right, anyway.
All right. That's all you have for that one?
Yeah.
Okay. How long should a new medic wait before accepting additional roles, such as management, educator, flight, etc.?
I would say at least 2 years. I don't like to put hard dates on things. I don't like the whole, you need 5 years experience to apply for a flight team, because we all know there's 5-year medics that suck, and then there's 2-year medics who are pretty good that might do a good job. But I have always said that the first 2 years of being a paramedic suck. It's fucking up, self-doubt, imposter syndrome. You're figuring out skills. You're figuring out assessments. You're developing gestalt and heuristics. So I think you need to get out of that stage where you are competent, you feel confident enough. You need to know the job if you're going to teach it or you're going to manage it. I always roll my eyes when I see some 23-year-old who graduated paramedic school in July and now in September is teaching the paramedic program. Like, what the hell do you know? Same thing with management. I'm sorry. I know management is different from operations, and being a good provider does not necessarily mean you're going to be a good manager. Like me, case in point. But
you were very good at both. You just didn't like management.
Nah, looking back, I don't think. Anyway, you made me lose my train of thought.
Sorry.
I don't think a manager that doesn't have experience doing the actual job has any legitimacy whatsoever. So, yeah, you need to have the skills solidified. You need to have your mindset and your operational tempo solidified before you do anything like teaching people or managing them. What do you think?
I'm actually going to disagree with you a little bit on that. Not in full, but I don't necessarily think you have to be a great or a good provider to be a great manager, but I do think that you need to have adequate exposure to that job as a provider to be able to manage it well, because you have to know what works for them, what doesn't work for them,
yeah.
What can be challenging, what is not. You can't just be like, oh, I'm great at management, so I don't, like, I've worked as a provider for 2 minutes and I can do that. You need to have that background to know.
I totally agree with you. Maybe I didn't verbalize it as best as I should have. I think that being a really good provider does not mean that you're going to be a manager.
Gotcha. Okay.
That's what I meant to say. There was a world famous cop here in Delaware who retired, and this department immediately latched him up and was like, he's going to be chief. This guy is a legendary detective and street cop, and he ran that department into the ground. And McDerby I said to McDerby, my friend who died last year that I talked about on the podcast, I said to him, I was like, what the hell happened with him? And he was like, great cop, shit manager. So, but yeah, I've also seen people who I think were weaker paramedics move into a management role. Not at my job, if any of you are listening. And I think they do a great job as managers. But would I necessarily want them showing up to back me up on a call? Maybe not.
No. So I do agree with all of that you've said. I just wanted to make it clear that I do think you need to have some exposure as a provider first.
What do you think as far as like nursing or being an NP? Because it's the
all
same thing.
Yeah, when you first started answering the question, I was thinking to myself, this is kind of the exact same thing with nursing. I've been a nurse for a long time, and even when I started in nursing, they always said, you should have at least 2 years of actually floor nursing experience before you even go into a specialty like ER, ICU, labor and delivery, anything like that, which I don't agree with that. But then it was, you should have at least 2 years before you go to NP school or anesthesia school or anything like that. I do agree with that. So I don't agree that you need 2 years as a floor nurse to go into specialty nursing, but it's not even considered specialty nursing anymore. I feel like so many people go into those things right out of school now. But I do think a minimum of 2 years before you go back for advanced training as an NP or something else, because the first 2 years, like you said, are just horrible. They're, you're learning how to be a provider. You have imposter syndrome, all of that stuff. It's tough. And you have to get through those first 2 years. It drives me crazy, too, when somebody has just become a brand new nurse and 6 months later they're enrolled in graduate school. It's like you don't even have... And to some degree, I think nursing, I honestly think you learn how to be a nurse more so on the job once you start working as a nurse. I think paramedics have a little bit of a leg up there during school. I think you just get way more exposure, like in the clinical setting, doing skills and stuff like that, than even nurses do. But I just think you need to get through those first 2 years on your own as a provider, learning your skills, and then possibly proceed from there.
You know what pisses people off that very few people agree with me about is that you said you were talking about you don't need to be a floor nurse before you go to the ER or ICU. I don't think you need to be an EMT before you become a paramedic. I think that's the way we've always done things. I think you can go from no experience right into a paramedic role. Newcastle County has shown that because they hire civilians with no experience and send them to paramedic school.
Doesn't Kent do that now too?
Yeah, all the three counties
I thought they all do.
Yeah.
Yeah. So.
All right.
Let's see. I think. Do you have anything else to add about like flight, or was there anything?
We're gonna talk
really.
a lot about
Okay.
flight in these next couple of questions.
Okay.
But yeah, I will real quick.
Thames.
You need a couple of years because you need to have the skills solidified. If you are landing, I'm not poo-pooing any other EMS role. It's all important. But when you land on a highway, you're the highest level of care there. It's just, yeah, I know sometimes it's lateral. The ground can do as much as the flight, but you land there, you're in charge. You're the head honcho once you land at a scene. That role is not the time to be unsure about your IV technique. You need to be good at airway management. I'm not saying to be a skills jockey, but you got to have those skills solidified to like lickety split without thinking, be like, oh man, I've missed my last 12 IVs. I really hope I get this one. Like, no, you need to have your skill set developed. All right.
Cool.
Same with Thames. Same with SWAT.
Okay. Yeah, that makes sense.
Yeah.
How did you know it was time to pursue being a flight medic? Factors that led you to making that decision?
All right. I took a unique pathway to becoming a flight medic because I never wanted to be a flight medic. And I was never ate up with it. I always thought about it, thought maybe I'll do it someday, but it was never like a goal of mine to be a flight medic. So I was burnt out at my job. I had been a medic for maybe 7 years, 8 years at that point, and I was an EMT for 5 before that. And I just, one day at work, I was like, I hate this job. I hate my partner. I hate my shift. I hate my department. I hated the patient that I was taking care of, and I didn't like his family. And I was driving home from work, and I called your boss because you were working as an ER nurse, but you were on the critical care transport team. That was your assignment. And I called her, and I was like, hey, I see you have a paramedic posting. And she was like, do you seriously like want to come leave the county and come be a ground transport critical care medic? And I was like, well, I hate my job, so yes. So I started doing critical care transport because I hated my job so much. And there was a flight team there was a flight and ground component. I was hired for ground. I did a year on the ground, and I transferred over to flight. I applied for flight, not because I wanted to fly so much, but because I thought it would be a unique challenge and something new. So there was a factor there. But quite frankly, we ran our asses off on the ground, and the trailer across the parking lot, they were a lot more chill. And that's kind of what led me to do it. I have never been one of these people all ate up with the helicopter. I think the novelty wears off after 2 weeks. And so that is how I decided to pursue being a flight medic. I know that is a unique pathway. I'm probably one of the only people, I would say, that applied for and got a flight job not caring about flying or thinking it was all that.
Yeah. You were kind of like indifferent about it. You were just like, I want to try something new, but like, this is not like my dream job.
Yeah, it's not.
Like, you weren't going to be put out if it didn't
I
work
wanted
out.
to be a tactical medic.
Yeah.
That is what I wanted to do. That was a goal of mine.
Yeah.
So, that's how I decided to pursue being flight. And I've just stuck around doing it. As you know, I love my job. I love my team, but I am not all ate up with being a flight medic.
No, but I think it provided you with a lot of amazing opportunities and experience. And I think you didn't realize how interested you were in the critical care aspect of things and the education that goes with that at that higher level of care.
And it's made me a better street medic
yeah.
because
You
it's
have
made
that
my
understanding,
clinical decision making much better.
Yeah. You can see like the whole picture way down the road, like once they're in the ICU and like what happens after that. And I agree. I think it made you a better provider. Okay. So is flying superior to ground transport, or is it a lateral move?
It all depends what you want. So clinical wise, I think it's a step up. Generally, You have better protocols. Generally, you operate with more autonomy. The standards are higher. There's more rigorous QA generally. So clinically, it's usually a step up. You're still going to do a lot of bullshit flights. The word stroke was invoked, and they have a GCS of 15 stable vital signs and a 20 gauge hanging out of their arm. You do a ton of flights like that. It's not all high-speed critical stuff. Job-wise, it's either a lateral move, sometimes a step down, depending where you're being. Some programs pay absolute shit. I was just talking to a friend of mine who left my flight team only because his family had to move to a different part of the country, and he said he loves his team. He said the care is, I hate the term, progressive, the protocols, he said, but the pay is shit. He said a new nurse working on a medical floor makes probably $10 an hour more than he makes.
How is that? Why?
This particular program does not pay well. This large corporation, they had a flight posting by us in Pennsylvania, and somebody I know applied for it, and he was a 10-year medic with flight experience, and they offered him $23 an hour. So I won't turn on a scanner and listen to a tone for $23 an hour. I'm sorry. So there are a lot of flight programs that know that people want to do the job.
I was just going to say, is that what it is? They can
and
get
will be
away
like,
with
well, this is my dream job. I know I'm going to make crap pay. So there are a lot of flight teams that don't pay well. My flight team, I get paid very well. The benefits are good. They take really good care of us. So my team, and I'm not just saying that, it's a step up, but other places are not. It can be a step down. There's a lot of drama and a lot of egos in the flight world.
Not at your base.
No, there's not a lot of
guys,
drama.
But some of the other ones, and I can say that because I am aware of the surrounding flight teams as well. So.
And sorry, not sorry, but you are now bringing an EMS mentality and colliding it with nursing. And that sometimes creates fireworks. And there's a lot of drama and backstabbing. I have had a lot of people DM me, and they're like, hey, I got onto a flight team. This kind of sucks. Yeah, it can. It can be very catty. But yeah, not my team. We're great. We're perfect.
Almost, right?
Almost.
You guys are a pretty awesome team. I do feel like you guys are pretty unique when it comes to flight teams.
Yeah, there's some drama. Don't get me wrong. There's always going to be interpersonal conflicts wherever you go. But yeah, compared to working for Christiana Care, where I am now is like lily rainbows. Anyway, I'll shut up.
All right. So
my dad would be freaking out if he heard me invoke Christiana Care.
I almost just freaked out at you too, but no.
I don't care. What are they going to do? Because my dad, we all worked for them. You worked as a nurse for them. I was on their flight team for like 7 years maybe. And my dad worked for them for 40 plus years. And when I was on the flight team, he called me and he was whispering on the phone. And I was like, why are you whispering? And he's like, because I'm at work and they'll hear. I'm like, you are nuts. You are crazy. But
I know. Well, none of us are there anymore, and that's a good thing.
Yeah.
All right. Should vents be common practice in all ALS service?
Yes. This is 5 years ago, maybe even 2 years ago, I would have said no, because I don't think that I would have said that not all agencies are trained or have the protocols or the knowledge or the infrastructure to safely employ mechanical ventilation. But now I have changed my mind. We are past the stage in EMS where we manage assisted ventilation with a BVM or one of those frickin' auto vent 3000s that you just plug in a tidal volume. Or no, you don't even plug in a tidal volume. Just plug in adult or peds and a rate.
Oh my God.
Like,
that's it.
That dangerous. What a great way to cause ARDS. So we are past the stage. They have studied bag valve mask ventilation a million times. Yes, bag valve mask your patients. 100%. But prolonged bag valve mask ventilation, they have studied it. You cannot, whether you're a doctor, a respiratory therapist, a paramedic, or a nurse, years of experience, you cannot for a prolonged period of time safely, consistently bag somebody at a rate and safe tidal volume. You just can't do it. Humans performing BVMs are fraught with problems for a prolonged period of times. The vents are available. They're out there. They're getting more affordable. Yes, I think that vents should be standard practice in EMS services.
Makes sense.
You heard Kirk. You can buy Hamilton for $16,000.
There you go.
The T1 used to be $38,000, I think. Don't quote me on that. It was maybe 28, around 30, maybe plus. But for EMS services, they take out all that ICU stuff.
Just put what you
and
really
they put,
need.
here's what you really need to do 911
That's awesome.
EMS. And people say, oh, it's too much vent. That thing's the Maserati of ventilators.
Is that specifically geared towards EMS? It's an EMS vent?
No, it's an
not?
ICU vent.
Oh, but they just take out the stuff.
Yeah,
you
they
don't
configure
really
the
need.
software. They're like, you don't need APRV, you don't need high flow nasal cannula, you don't need, all the neonatal BiPAP or CPAP, stuff like that. So they take it all out, and here's what you need. Yes, and with this ASV, adaptive support ventilation, that should be a standard vent mode for pre-hospital 911 services. It is the perfect mode, in my opinion, not being a respiratory therapist, for an EMS service that doesn't do vent modes every day to freshly intubate a patient and put them on a vent. The vent does all the work.
Does Melody agree with you on that?
I think she would.
All right. Cool. Very good. Volume or pressure mode. Obviously, this is a bear trap. Please step in it.
Yes. I will quote Melody. She said the first time she came on the podcast that people jump all up and down about volume and pressure, and there are different considerations for some patients should be on pressure, blah, blah, blah. But at the end of the day, volume is pressure and pressure is volume. If you deliver pressure ventilation to somebody, it's going to deliver volume and expand the lungs. If you deliver a preset volume to somebody, that is going to generate pressure. Follow your protocols, but at the end of the day, I think as long as you are adequately ventilating the patient based on their numbers, how comfortable they look, I don't think it really matters. And the Hamilton T1 does not deliver preset volume. Like, that is strictly a pressure ventilator. It is volume targeted. It will deliver pressure. You put in a volume, and it will deliver pressure till you get to that target volume. So people jump all up and down and debate volume or pressure. At the end of the day, they're both the same.
Good to know. All right. Thoughts on under 18 in EMS? Are they too young to ride along, given the gravity of some calls?
Well, you worked in peds for a while, and you're a mom. What do you think? And you worked EMS, and you...
So, I mean, I guess I would say that it depends, but generally, I think it's okay for somebody who's 16 or 17 to do a ride along, to just observe and see how things are, if they're interested, see if it's a career that they might want to get into. I don't necessarily think it's something that they need to be doing, like volunteering weekly and doing it all the time. I think once they turn 18, maybe. But again, I think it's child dependent. Everybody is very different. You may have a 16 or 17-year-old that is very, very mature and can handle things. And you may have a 16-year-old that shouldn't be on an ambulance until they're like 28. So, I mean...
as I said, I know 35-year-olds who can't emotionally handle the job.
Yeah.
I mean, another content creator did a stitch with the reel that Cody and I did that really pissed everybody off, where we talked about sometimes as an FTO, you need to dress down the student and have a tough conversation with them. And as Cody said, chew ass. That's what really pissed people off. And somebody did a stitch where they said that if an FTO did this, like, that could trigger past traumas. Like, you know what? Sorry. If getting reamed out by a supervisor or an FTO is going to make you a blubbering emotional mess, maybe you shouldn't be responding to or working in a profession where you are responding to emergencies. Sorry, unpopular opinion. People are going to jump down my throat for saying that, but not everybody's emotionally cut out to do this job.
Right. And so especially if it's a minor, and you don't know like how they're going to react. Are they going to be that way? If they're not like emotionally kind of mature enough yet, then maybe it's not. So it's very independent.
I do think it depends on the kid. Like, I think if our son Michael did a ride along and saw somebody run over by a bus, splattered and dead, I think he'd kind of be like an empath about it and think about them and their family and kind of be upset about it and be quiet and say, oh no, it's fine, but like internally
be upset about it. Yeah.
And then I think Elena would see that and come home and be like, that was the coolest thing I've ever seen.
I don't know if that's a good
Sign
thing.
me up to be a paramedic.
We're not horrible parents, I promise.
But no, it's just some people are like that. You know, we all talk about, going back to the mental health thing, we all talk about processing and dealing with the things you see. And Alex Jabber, when she came on the podcast, she's trained in this stuff. This is her specialty. And she said, yeah, like all the stuff you go through is totally normal. But you know what else is totally normal? Is being absolutely fine when you see something.
Yeah.
She said that's totally normal. And, you know, she doesn't want people to think that they're fucked up because they go to some traumatic call and they're fine.
They're fine, yeah. Well, one thing that has always stuck out in my mind from my experience in EMS. So we started EMS in college, and you sometimes don't know what you are not going to be okay with until it actually happens. So I had been, I don't know, I've probably been riding the ambulance for maybe over a year, close to 2 years maybe. And Mike and I actually responded to a bad accident on the highway. There were tons of other units there. It was a fatal accident, teenagers. And I had never gotten really upset by a call before. And it was the first time that I had seen somebody that was very close to my age just deceased in this mangled car. And I was fine, obviously, on the call, but afterwards, I got really upset and I kind of had like a mini meltdown. And it was that first time that I could relate because the person was close to my age. And I was like, oh my gosh, this is like really sad. And you know what? I've had a long career since then and I've been okay. But you just never know, like that first time that something's going to hit you a certain way. And I was still fairly young at that point. I was maybe 19 or 20. So you just never know.
Yeah. I had a call that put me into therapy. And then, and kind of like was part of that whole downward spiral in my early 30s, if you recall that.
Yes, I'm very well aware.
It wasn't just because of that call, but it was I got diagnosed with PTSD. And when the shrink said that, I'm just being honest, my response to the shrink was, no way. And he was like, no, you dumbass. And then he went through the different symptoms. He's like, tell me I don't know what I'm talking about. And I was like, you have a very fair point. So fast forward a few years later, this is just in the last couple of years, Alyssa and I landed on the highway for this awful accident. Drunk mom rolled her car over, 5 kids unrestrained. And then after they rolled over and came to a stop, an 18-wheeler just plowed into them and killed
3 of the 5 kids?
There was a
3?
toddler splattered on the highway. There was a dying kid. And then we took care of the brother, who was like all broken apart, but he's conscious. We're getting ready to RSI him. He's asking about his brothers who are dead. And I was like, oh my God, this is going to make me go crazy again. I was fine. Mm-hmm. I'm not trying to sound tough. But to Alex's point, like,
you just don't really know what's going on.
Yeah, I felt empathy for the kid. I felt terrible for him, but I was like, I was fine.
You did your job, and you were like, oh, okay, I got through it, and
let's get breakfast. Like, you're right. You just don't know what's going to bother you and what's not. And then I'll go to a nursing home call, and I'll be like pondering my own mortality, looking at some 90-year-old. Who
is having like a fairly natural death. They've lived a long life, and you're like, you shouldn't be that upset because it's kind of expected, but you're like, oh God, I'm kind of like 20 years away from this, or whatever. But not 20. That's really young.
But going back to the question, I think it totally depends on the kid.
I
really do. I really do. What I don't think, and I agree with you, is that you have these people who are 16, 17, and they live at the firehouse or at the ambulance station. One, I don't think that's psychologically good for them. They need to be teenagers. They need to get out there and live. But operationally, I see this a lot where there are volunteer fire departments, is that you have people who started riding as a junior at 14 or 15 years old. And then when they get older, they're this 24, 25-year-old know-nothing with little experience. But then people go, well, they have 10 years in the fire service.
And that's all they have done. They have done nothing else.
Yeah. But they're like, no, your time as a junior riding along and helping reel in hose or just sitting there observing calls on the ambulance does not mean that you have 10 years of experience. So I see people going into these officer positions that have no effing clue about anything.
Yep.
All right.
I agree. All right. What is something you struggle with understanding today?
The clotting cascade, but neonatology. I don't do neonates. My extent of taking care of neonates is responding to babies in the field. I don't do neonatal critical care transport. So the couple times I had to teach a flight medical provider course by myself, I was just straight up honest with the class and was like, I don't know jack shit about this, but like, we'll get through this module. Sorry, they should have sent 2 instructors. So I struggle with the blood flow and the physiologic changes and what closes when the baby starts to breathe, because I just don't do it. I don't have to do it. When I review it to teach, like, okay, this kind of makes sense and it's all coming back. But I don't feel that I can eloquently and validly teach people about neonatology. Another thing that I struggle with understanding are balloon pump waveforms, the timing waveforms. I've tried a million different ways to learn a balloon pump timing waveform. It's just, I'm never going to get it.
But you're totally comfortable with balloon pump runs.
Yeah, 1,000%, because this just goes to show that the people who write the questions haven't done patient care since 1974. Because now, balloon pumps, I'm not saying you won't get a timing malfunction on a balloon pump, but they now have fiber optic cables, and the computerized algorithms are much better than what they were in the 80s, 90s, even early 2000s. So Bill, flight nurse Bill, he works part-time in a cath lab, and he says that, you know, he uses balloon pumps all the time and that he's never experienced a timing waveform. He's like, the fiber optic cables, he's like, there's no reason to even really know the waveforms. That's just what he says. Somebody else may disagree. So when I have to teach balloon pump waveforms, I'm right up there with like a note card and bullet points reading off. All right, here's what you need to know. I'm going to read off the points here. And my recommendation for if you get a question about a balloon pump waveform, and this is what I did, was C. C. When I was studying for the FPC exam, I was like, I'm not going to figure these out. These are stupid to know. And I'm not going to dedicate any more time. I'm going to learn the other material. And if I get a question about a balloon pump waveform, I'll just see.
And it's just the main thing. The main thing is just balloon pump waveform timing. That's the only
to
aspect.
Identify a timing
gotcha.
error. Yes.
Okay. All right.
I'm not saying it's unimportant. It's just not something you're likely to encounter.
All right. And maybe if there's a listener out there who has some super, super easy way of determining balloon pump timing, maybe you guys can share, because
that's something I don't understand. And you know what? Now I'm going to get DMs from all these people like, oh, we had 4 timing waveforms last week.
Maybe they need new monitors or equipment then, if that's the case.
I don't know.
I don't. All right. So how do you how to approach debriefing if no one else on scene wants to participate? Which I feel like that I have seen that happen before in EMS and in nursing. Like, everybody's like, oh, I'm okay. Like, I don't know, we don't need to debrief. Like, I'm okay. So how do you approach that?
I also think this meant like operational debriefing.
Oh, okay. All right.
Yeah.
So
as far as psychological
like
debriefing,
okay.
I don't know. We'll talk about the psychological thing first. people disagree on this. I'm not a mental health professional, so I don't know. I know Boomhauer's big on schism, but I also know our friend Missy, who went to grad school and has become a licensed therapist that is dedicated to first responders. She is big anti-schism and says it does more harm than good. So there's definitely a debate about it. I disagree with forcing people in particular to participate in schisms. I have participated in a schism before. I feel like I didn't get anything out of it. My friend John was forced to participate in a schism. He was a cop. They responded to a school for a burglar alarm, and when they arrived at the school, a guy came running out of the school into the woods. They chased him. His partner was faster than he was. They ran into the woods. He heard a gunshot, and when he got up to the other trooper, the trooper had shot the guy, and they had to go to a schism over it. And he said it was just like a giant joke, and that the person conducting it was pissed off because they were laughing about it. And John said, well, the first thing I thought when I got there was to say, that wasn't the guy that ran out of the school.
Oh my God.
And then the person conducting the schism was like, you guys need to be really like careful about being dehydrated. And he said another cop was like, why? From all the tears we're going to be crying. So I don't think forcing people to go to schism is a good thing. And again, I'm not a mental health person, so I acknowledge I could be totally wrong. Operational debriefings, if nobody wants to participate, do it in your head. Do it yourself. I do this all the time on the ride back from the hospital or on my ride home. I think about things, what could have gone better, what I did well, what I didn't do well. And I will take a learning thing, and then I will deep dive. I'll go into PubMed. I'll go into Google. Dave Salati and I had a patient with an aortoenteric fistula. I had never had one of those before. He said he's never had one before in his 45-year career. So that's something I deep dove into. So debrief it yourself. I get as much meaning or benefit from doing that as I do going to a formal operational debriefing.
Okay. Yeah, no, that makes sense. I actually, even with the patients that I see at work now, every once in a while, I will get a patient that has a diagnosis that I've either never heard of before, if it's something really very rare, or if it's something that I haven't, heard about or looked into since nursing school or NP school. And after I'm done working for the day, I'll go look it up and learn more about it, or just to refresh myself on it, just so if I have that come up again, I'm more aware of it. So that makes sense.
Yeah.
Okay. What is a dispatch notification that makes you feel nervous?
I don't go off of the dispatch anymore. We all know that the medical priority dispatch system is a crock of shit. Everything is a difficulty breathing call. Any altered mental status is a stroke. It is a dog shit system. You could take a chimpanzee, and remember years ago they had a chimpanzee blindly pick stocks, and then they compared how the chimpanzee did to a formal stockbroker, and the chimpanzee actually did better than the stockbroker. They gave a chimp a highlighter and
just
randomly high. And I think you could apply that same scenario to dispatch, and you would get better accuracy than the medical priority dispatch system. I've always said that there's a county that we cover on the helicopter. They use no formal algorithms. It's very antiquated 911 center. The dispatcher, call taker picks up the phone, and they triage it just based off of intuition.
It's more accurate.
I think they're more accurate. I really do. So yeah, you can't go by the dispatch, but anything involving a vagina does make me nervous. We talked about this on the last episode. I don't like babies. I don't like childbirth. That makes me nervous. I will say, though, going by CAD notes, dispatch notes, anything that involves the patient being in the bathroom is a bad sign.
100%.
Because when people get sick, they go to the bathroom. People also go to the bathroom to die.
Often also to kill themselves.
But anything in the bathroom is a bad sign.
Yeah.
Our neighbor, he died. Just a couple weeks ago.
Yeah.
And what was the story? He got sick. He went up to go to the bathroom, passed out, and by the time EMS got there, he was dead.
Yep.
I mean, he was 90. But yeah, anytime I get a dispatch in the bathroom, patient in the bathroom, I think, okay, so
It's gonna be bad.
this could be bad. Yeah.
All right. How do I convince my medical director for the case for pre-hospital blood? He is vehemently against it.
I don't think you're going to convince your medical director to get on board with pre-hospital blood
Get a new
if
medical
he,
director.
she, or they, them is vehemently against it. And the reason that I say you're not going to convince your medical director is because modern medicine has not yet found a cure for mental retardation. If your medical director is not on board with it, they need to pull their head out of their ass. You don't get more evidence-based medicine than, I think, pre-hospital blood administration for a hypotensive trauma patient. You can debate medical administration of pre-hospital blood. That is a valid debate because there are things about restrictive transfusion strategies for anemic patients and for patients even with GI bleeds, even serious GI bleeds. But when it comes to trauma, the Broom study, who else? The Duchesne and Dr. Mark Peel, he was involved in that New Orleans study that showed it was an 11% mortality increase with every minute that patients in that study didn't get pre-hospital blood. The evidence is smack in the face. These medical directors that still are against pre-hospital blood are like spouses whose husbands come home with a weird story about where they were, smelling like perfume, with red hairs attached to their clothes, and text messages that say, hey, come over and fuck me when your wife isn't home.
Wow, okay.
And they're in denial that they're having an affair. That is how stupid these medical directors are that are against pre-hospital blood. There are medical directors out there who were against it, and I know a couple of them that are now scrambling to get pre-hospital blood because they realize that it's a good thing, and hey, we look stupid because now everybody around us is doing it. So that is my advice. I don't think you're going to convince that medical director because they don't. If they don't want to do it, you can't fix stupid. You just can't. But I would show evidence because there is plenty of it. And the evidence, in quotes, that is against it, like the Schoenfeld paper, was a laughingstock. An absolute laughingstock. I mean, I didn't go to Harvard, and I'm not a Harvard author or researcher, but holy cow. I mean, I've got some intel from the academic emergency medicine community on the farming of that paper and how the editors responded to it, and how academic emergency medicine, the journal, some people there were kind of like, oh, they didn't, I don't know about them saying anything, but as somebody in the know told me, they said, I have been in academic emergency medicine for 30 years, and I've never heard an editor say X, Y, or Z. That was very telling to me. Mm-hmm. So the evidence that is anti-pre-hospital blood is bullshit.
All right.
Do I feel strongly about it?
Yes, very much so. Yeah.
Speaking of pre-hospital blood, Dr. Mark Peel from the Broom study, inventor of the life flow and huge proponent of EMS blood. He is going to be at the FDNY conference, and I am pretty sure I'm going to it. Let me find this.
Our anniversary weekend?
Yeah.
Yeah.
Our anniversary's that Monday. It is April 24th through 27th. I think the meat and potatoes of the conference is the 26th and 27th in New York City. He's going to be there. He asked me to put out something about it, so I told him I was.
What is the, did you give the name of the conference?
It's the FDNY. It is the FDNY Search and Rescue Field Medicine Symposium.
All right. Is it at a hotel or something in the city?
It's at the FDNY Academy.
Oh.
So all the whackers can go there and be like, yes, I did some training at the FDNY Academy.
All right.
So that's what I've got. Do you have anything else?
I don't think so. I'll get the store, the merch store, updated today. And like I said, just let us know if there's any additional merch that you would like to see or anything that we're out of that you would like restocked.
Yeah. And thanks to all those who have signed up for the Patreon. People are still signing up for it.
Yeah,
So
awesome.
very much appreciate that. All right. That's it, people. Talk soon.